please allow me to introduce our guest presenter, Damien Paulk. Damien works at a large academic facility in Baltimore, Maryland, where he has been practicing as a member of the vascular access team for the last 3 years, caring for the adult population at his facility. He is also the chair for his department's committee, and he is teaching new hire orientation. He's providing the skills of that new hire orientation for vascular access. I know that is not something that is standardized everywhere, but I think that gives a little bit of insight into the innovation and progressive nature of Damien and his team at their large academic facility. So without any further ado, I'm going to go ahead and turn things over to Damien. And Damien, welcome.
Thank you so much for having me today. It's really nice to see some familiar names and faces. I am here to answer anything and everything, help demo things, just whatever you have as far as questions or concerns, comments, shout them out, raise a hand, put a comment in. We're going to cover everything today. So starting off, I see that Scott had asked, are you going to discuss benefits of SecurAcath rather than StatLock? Yes. So like Matt said, I've been working in vascular access for about 3 years now. Thank you for hiring me, Sasha. At our facility, we use SecurAcath, and we also use StatLock, which is an adhesive securement device. As far as benefits of SecurAcath versus StatLock, number one is prevention of pistoning of the insert or the line in and out of the insertion site, which can increase your chances of line infection or CLABSI. The SecurAcath here gives really great confidence to the inserter, to the nurse at the bedside caring for the patient or at home, a lot of confidence in changing those dressings. So because it is a subcutaneous anchoring device, it'll be on this line until the necessity for the line is done and the line gets pulled. On top of that, because it's going to be staying on this line, unlike the StatLock, it doesn't need to be changed with every dressing change. It just gets cleaned, and then you put a new dressing on, call it a day. So we don't have to worry about the added cost of more and more appliances. We also don't have to worry again, like I said, about the pistoning of the catheter in and out of that insertion site. And what I like to tell people during orientation is, if we have a stat-locked line or a line that is secured with the adhesive securement device, once that securement device comes off, you then become the securement device. And being very mindful as to making sure the line does not migrate out, because once it comes out, we know it can't go back in. So with all that being said, the SecurAcath provides a lot of great confidence and then helps to keep that line lasting a lot longer and a lot more secure versus other devices. I hope that kind of answered your question in a very long roundabout answer or way.
The next question I see is a question about how long it can stay in place.
So great question. Thank you. This SecurAcath, I am having a lot of trouble with S's today. The SecurAcath can stay there for as long as the line is needed. And the population that I've been caring for, we've had some patients that have moved across state lines and just kind of fallen in the cracks in the system, unfortunately. We've had patients that have maintained PICS with SecurAcath for upwards of 2 years. Even though I'm predominantly in the adult population, I also work in our pediatric side of our facility as well. I don't insert the lines, I just help care for them and do the dressing changes. And we've had some little kiddos that have been waiting for either transplants or just whatever the case may be. They've maintained their PICS for about 2+ years, I believe, is our longest one so far. So as long as we have that need for the line, there's no chronic complication, no signs of infection, we can keep on with this line and keep on with that securement device, and it will keep it nice and snug.
And we have a case study actually posted on our website that was in Baltimore area as well. And that patient was an adult TPN patient who maintained a non-cuff tunneled line in the chest for over 5 years with a single catheter and a single SecurAcath. So that's the longest that we have on in published record. So there could be longer ones, but that's what we know. So basically the answer to the question is, as long as the catheter is working and indicated and SecurAcath's keeping it there, you can leave it in.
And then kind of I touched on it a little bit as I was explaining about the benefits of the SecurAcath, is that with your dressing changes, you can really get a whole 360-degree clean on that insertion site because it's anchored into the skin. I'll kind of bring this a little bit closer. Because it's anchored underneath the skin and the sub-Q tissue, whenever you're cleaning, you can actually lift the line up a full 90 degrees and then get that whole 360-degree clean around here. Scrub the back, scrub everything, let it hang out. And once it's dry, apply any other devices that you may be using, such as like either a CHG gel pad, biopatch, any other kind of disc devices as far as like antimicrobials. Apply your dressing and then run away.
Since you're on that topic, do you mind doing an actual dressing demonstration and how you would apply the dressing?
Of course. So, of course, I would have sterile gloves on and perform hand hygiene, important things. But once I get the dressing off, I will actually, I got a couple dressings here. Sorry about the noise. So we're going to pretend that this was our old dressing here. So I have my dressing on here. Once we go ahead and start taking the dressing off, I like to be very careful not to touch anything underneath the dressing, but that's just me. I'm very paranoid. And one helpful hint is that sometimes these dressings tend to kind of get glued onto anything underneath the device. What I like to do is just kind of stretch a little bit, and it will help to get that dressing off. So dressing's off. We go ahead and start cleaning. I always lift up, get a whole 360-degree clean here. We've also seen in our practice that by lifting this device and cleaning all around here, it also helps with mobility of the skin and then helps with removal of the device once it's time for it to come out. But go ahead and clean everything there. And then, as I kind of mentioned before, it's perfectly safe to use for any other applications that you might be using. So at my facility, we use CHG impregnated Teganers. So once everything is done, I can just go ahead, get it nice and centered a little bit right there. Go ahead and press down, making sure I've got my gel over my insertion site. I always struggle with this because I don't have nails.
And I will say, I'm very excited to see that you always make sure that purple hub of the catheter, whatever color hub of the catheter it is under that border of the dressing, because that is a crucial aspect.
You also have a little bit of a slit that you can expand for your larger lines. And then taking my reverse here. Up and around. Sorry, my hands are all in the way. I'm going to cheat a little bit because I want to make sure everything is nice and covered. We're just going to do one extra date strip. Because you never want everything hanging out of your pants. Always got to have a belt on.
Just good advice in general.
Yes. Yeah, you never want to Winnie the Pooh your dressings here. And then that is your very abbreviated and quick dressing change. But like I said, it works with all of the CHG gel pad products. It works with the biopatch, any other kind of antimicrobial disc device you may use at your facilities. Works perfectly well. I know with the BioPatch here, you have your little slit. So it's just going to go around your insertion site here. And then a helpful hint is because I think the IFUs say a 10-degree turn, just making sure that your slit right here is just oriented to either of the wings here of your SecurAcath. That'll help it to stay in place and then help with device removal on your next dressing change.
Awesome. And since we're at the point of having a good, clean, dry dressing, I'll ask if anyone has any questions related to dressing application or dressings before maybe moving on to showing how you remove the device. I'll give everybody a second to maybe post a question if you've got one. Feel free to use the chat function. Or if you are on a phone and can't use the chat function or don't know how, feel free to unmute and just ask your question out loud. I see another question here posted, says, can we use secure port glue along with stat lock? This prevents cath movement as well, correct?
Yes. So we also do utilize secure port in some cases for our patients at my facility. Secure port glue can be used at your insertion site. It is perfectly safe to do so. We have found that it's helpful whenever you do your dressing change, you clean, of course, let it dry. And then once you're ready to apply your secure port, you lift up your device like I showed before, apply your secure port, and then lay it back down to allow for that cure time. And then your dressing can go on top of that. And yes, so like you mentioned, secure port can help with prevent catheter movement. But with the SecurAcath, this line is not going anywhere unless Ethel is just raging out on her UTI and then just yanks it like a lawnmower.
Yeah, I would advise to just limit the application of glue, to your point, holding it upright, a couple drops, letting it cure, then laying it down. We don't want to see that glue migrate underneath the device, because we can imagine that if somebody didn't know that that had glue underneath, it would be difficult or uncomfortable for the patient at the next dressing change or at the time of removal. So, and during dressing changes, we also advise that you do use either an adhesive remover or some type of dissolvent to eliminate all of the glue that's visible so that you don't have an accumulation of glue at the site.
All right. And then I see another question asking if a CSG gel pad can be used on under the SecurAcath, and yes. Another practice that we utilize in our facility, more often than not in our pediatric population, we've noticed that with very small little babies, so our team does place lines in the NICU, in the PCICU, PICU populations. For those kiddos that are very, very small, also very, very fluid overload. Same thing in the adult population, our fluid overload patients. We've noticed that because we apply the dressing, over time, they do tend to bring on a little bit more fluid. There is that little possibility that if anyone's concerned about device-related pressure injury on your dressing changes, we have started using a split CHG gel pad that can go underneath and provide like a little pillow for our SecurAcath to sit on. We've also utilized other products. So in our stat lock packaging, there's a foam adhesive strip, and we'll use sterile scissors to cut that and make like a little T. So one that goes down and then one that goes across here underneath the SecurAcath. Again, just providing like a nice little cushion or bed for it to sit on. And of course, applying the dressing, what we typically call a plop and drop. So just nice and gentle on the insertion site, smooth your way out to prevent any kind of stretching of that dressing that will put too much pressure on.
And do you mind talking about like a patient that might have fluid shift or edema that happens post-insertion, maybe post-initial dressing application?
Yes, so that is the other amazing thing about the SecurAcath is that we have seen, I'm not sure why, but an uptick in some of our patients that have fluid volume overload and are just kind of weeping from every pore and every surface on their skin. Even though the dressings we're having to do very frequently because they're not sticking too well, because this is a subcutaneous anchoring device, it is anchored into their limb. And this line is not going to go anywhere, unlike if we use any kind of other adhesive securement device. The patient can either sweat that off, weep it off, whatever the case may be, and that line can potentially dislodge. We've also been, you can also utilize other products such as like I think biotin we've used, Mepilex transfer, stuff like that to also go underneath the device, and that will help with moisture absorption, wicking of the moisture, and won't affect movement or migration of your line.
Fantastic.
And Damien, is it correct to assume that those are interventions that you would use even if you didn't have SecurAcath there? Sometimes like to manage moisture and some of those other benefits that you described?
Yes.
Okay, good.
And if you have dressing adherence, Mastisol is such a fantastic product for keeping those borders down, especially on those sweaty patients. So that's always
Yes,
a good
I keep
option.
a fistful of it in my little go bag that I take with me to all of my patients. We have actually implemented using it on all of our pediatric kids under the age of 1 and under, just because they move so much. So we utilize the Mastisol quite a bit in my facility. Just if you do use Mastisol, because it is an adhesive, you need to use an adhesive remover, whether it's the Detach-All or any kind of other adhesive remover products.
Absolutely. And I personally love that Detach-All. I use it to remove all of my daughter's Band-Aids and dressings.
I've had a couple find their way home in my pocket, and they're great for taking off really big Band-Aids.
Yeah, for sure. Well, I don't see another question post. I'll encourage everybody to continue to post questions or unmute if you've got one. I love that you have Detach-All in all of your central line dressing kits. That's amazing. I just saw somebody post that. Thanks, Sasha. If you could take off that dressing for us, as you would, and show us how you remove SecurAcath when the line is no longer indicated for dwelling.
I'm going to try to do it without getting my big old paws in the way. But I always go after the date strip first. And then whether I use Mastisol or any other kind of adhesive, I always use adhesive remover, whether it's the wipes or the Detach-All. The Detach-All is like gold in my facility, so sometimes people tend to hoard it and I can't find it. So just some sort of adhesive remover. But like I was kind of doing before, I get all of my edges up, make awkward conversation with my patient while I'm doing this. Let's stick again. There we go. All right. Once my dressing is off, it's time to take out our device. So I don't know if you can kind of see here. Actually, you know what? I'm gonna move this away for a second. Boom. So with your SecurAcath, you can kind of see here, there's a place that says hold. And then what I like to do is I will hold here and then bringing this back. So like, whoop, I don't know what directions are. Good. Hold here, and then it says lift here on the lid. So what I tend to do, hold, and I just kind of pop up, and it kind of comes to the left like that. Take my little lid off. And then at my facility, we always remove the device, then the line. However, you can do it either or. Sometimes it is easier to remove the line first and then the device. But I just flop that little guy forward, and then I just slip a little finger under here just to help me fold it in half. And you can see that it folds in half right where that little blue channel is. So I have it folded in half. I'm going to hold my line here. Sorry.
That's perfect.
Hold my line. And then the most important thing that I tell all of our new staff if I'm helping orient is whenever you remove it, to just remove it. Don't take it too slow. Don't try and baby it. The quicker you can do it, the better, almost like doing a shot, just 1, 2, 3, done. I always like to just pull straight out as well. If you kind of tilt upwards and then try to pull it this way, those little nitinol feet are just going to cause a little bit of discomfort on removal. As you can see here, little big model, whenever you fold it in half, your little feet, make like that little hook. And so if you're trying to pull it under straight out, like perpendicular, those little feet are going to catch on the skin, and that's what's going to cause discomfort to the patient. Versus if you lift up, it just comes right out. So again, I'm going to just tell my patient, all right, you're going to feel just maybe a little bit of a pinch, 1, 2, 3, and it just comes right out. There's two different ways. So there's the fold and remove. The other method I use kind of more as my backup is some patients, usually like in our pediatric population, because they have they're just always growing, or adult patients that have had these lines for quite a long time. Sometimes they can form, the skin can grow around the insertion site a little bit, or they might have a little bit of a scab. Sometimes the fold and pull method doesn't quite work well. So the other alternative is the cutaway method. In this case, you would take a pair of very, very clean scissors, and you can cut down the blue channel down the middle and make it into 2 different pieces. So going back to my giant model here, you can cut it down straight down here and make it into 2 different pieces. Fold one, take it out, fold the other one, and then take it out as well.
Yeah, and if you're recutting, you definitely have to have the catheter removed.
Yeah.
Yes, please do that.
Do you typically leave the catheter in place when you use the fold method?
I keep it in place. That was how I was trained at my facility. However, like Laura pointed out, if we are having to resort to using the scissors to cut the device in half, I will remove that just to prevent accidental cutting of the line and retained catheter.
And I will say too, like our most common challenge is that there's tension in that area. And so when we get those calls on the hotline, we instruct to remove the catheter and achieve hemostasis, then remove the base. And if you can lift the catheter while the lid is still on freely, you should be able to successfully fold it and remove it the way Damien showed it. So those are just some highlights from our experience managing hotline calls and phone calls. And that'll give me a chance to plug the hotline. If you don't already have it, you can download our app. I'll ask Jeff to post links to the app on here in the chat. You can download it either from Google Play or Apple iOS. And it's free. And inside embedded in that is not only our training videos and quick references, but you also have the little phone icon, which takes you directly to our hotline. So if you ever have difficulties or questions, we're there to answer them 24/7, not just on these occasional drop-in sessions with fantastic people like Damien. Can I ask you, Damien, somebody posted a question about burn patients. Do you have any experience using SecurAcath in burn patients?
Yes. So at my facility, I believe are the actual regional burn center for our pediatric population. So we do have quite a few burn patients that come through. And again, these are our patients that tend to, after that acute phase, tend to kind of swell up when we have a lot of fluid retention. So again, it works really, really well because it is being anchored underneath the skin. So this is more of on the insertion side. It just goes in, goes flat, and then our line will lay in through here. I have, of course, migrated mine just a little bit because I was not securing it. But lift that up, click it down. Because it is anchored to the sub-Q tissue and not anchored to the skin, you can have patients with that impaired skin integrity and maintain this line very securely because it's going into the sub-Q tissue, again, not sticking to the skin like it would with any kind of adhesive securement device. Like I mentioned before, our patients that are fluid volume overload that are weeping from any kind of puncture or any kind of puncture site. And then also for as you mentioned, Val, our burn patients, any kind of skin sloughing, we don't have to worry about our device sloughing off with the skin as well. It's staying secured to the arm or whichever extremity the line may be in.
Fantastic. And
Oh,
any other?
and sorry, Laura, I
Okay.
will plug the SecurAcath resources a little bit more for you. We did have a patient that I placed a PIC line in. She was from out of town, just happened to be in the neighborhood. We ended up having to replace her line because of a complication with the previous insertion. Put a new line in her. She was hanging out in the area for a little bit and then went back home. She lives several hours away, and we're in Pennsylvania. And I just happened to be working the day that we got a random phone call from the operator saying, "Hey, this patient has a question about something called a PIC. Can I forward them to you?" I was like, "Sure." And it was actually the mother of the patient of the line that I put in. And she was calling me or calling the hospital because it was time for the patient's PIC to come out. The facility they were at had never used SecurAcath or heard of SecurAcath before. And so they were going to send her 4 hours back to my facility just to have this PIC line removed. So I was like, wait, don't let them send you. I got you. I got with every line insertion that we do, if we're placing a SecurAcath, we do have a SecurAcath pamphlet. I unfortunately don't have one with me, but we give it to all of our patients along with other PIC information. And it has the QR code for the App Store. It has the hotline. It has the website. Also, it has the printed care and maintenance and removal instructions. Unfortunately, it got lost in transit. So I was like, hold on. I got her email address. There we go. Thank you, Matt. I got her email. I sent her the link to the website, and I scanned in an image of the QR code and the resources on the pamphlet, sent it to mom. They were able to get the line out that day and did not have to travel 4 hours to come back to me. So there are plenty of resources out there. So don't worry about having to travel 4 hours to have this device removed. There's plenty of help out there.
And I know your hospital, I think, does this routinely too. When you hand them the guide, you ask the patient to scan the app. Is that still part of your team's practice? Because I know Michaela was doing that. And
it depends on my patient's experience with technology.
gotcha. Well, I thought that was the coolest thing. So I teach that now, is that, that's a way to make sure that if they lose the paper or they lose the card or the wristbands now that we have all of these options for patient communication, is to just download the app if they have the smartphone available to them. And that way they can share that app with the providers that are in their care plan, if they're at the facility that placed it or at another outpatient clinic or down the street or down 4 states over. That app is always available. And again, like you said, the website, we have a chat bot there. It is a bot, so it doesn't answer questions unless it's pre-programmed to answer them, but we do have that hotline where we have support 24/7. So we encourage people to use all of those tools and encourage the patients to have those tools at their ready, and empower the patients to use those to advocate for themselves, so they're not having to drive somewhere or go back to the ED for their line removals. It's never necessary.
Yes. Aside from use on PICs, this can be used on any other kind of percutaneous or tunneled cuffed catheters. In our oncology patients, it is now our standard of practice to use SecurAcath on all of our PIC insertions with them. Our IR team also places SecurAcath on all of their lines that they're placing in our oncology patients as well. Like I said, whether it's percutaneous or tunneled cuffed catheters. I believe they range in sizes from 3 French all the way up to 12 French. So there is a vast array of sizes to use on any of your lines. I did have a case where I was doing central line rounds, and this patient had a percutaneous non-tunneled IJ that for some weird reason, our sutures just kind of popped out. And the patient had very flaky skin. So even with the stat lock, it kept coming off. We were doing dressing changes every 24, 48 hours. Of course, every time that dressing comes off, we increase risk of line infection. And then because of that, not so stable securement, our line had also migrated a little bit. I think it migrated about 2 centimeters-ish. Thankfully still central. However, at that point, I just made the judgment call, called an audible, and did a dressing change, put a SecurAcath on it. Through the help of my awesome network of people at my facility, I was able to find a 7 French SecurAcath, threw that on there, and then that line stayed in place, I believe, for like another week and a half. And then he finally got a tunnel line, thankfully. But like I said, it can be used on a wide array of devices, lines. I only deal with vascular access stuff, but it can also be used on drain tubes. So there's a lot of different applications for these devices, and they can help save you some time and heartache.
Fantastic. Thanks for that insight too. It's a challenging story, and to know, our acute central lines stay in so long sometimes with our ICU patients and critical patients as we're managing them, especially with increasing severity of things like ARSD and COVID still being out there, having patients that are in the ICU intubated often. It's a great way to get those lines out of the airway and down onto the neck, from the neck down onto the chest, so that we can optimize those dressings and avoid the sutures altogether. So thanks for that insight on the patient that you had. It's good to hear that we're continuing to see that growth and progress on central line applications as well. Are there any,
because like instead of it being like up here next to his eyeball, I was able to dress it down over into the clavicle, and so much better.
Make every nurse in your hospital happier? Awesome. That's so awesome. I am curious if anybody has any questions. Again, a reminder to post in our chat if you do, or you can unmute if you'd like to just ask your question out loud. Please feel free. We're very excited to hear your questions.
I would like to say, as far as insertion, it is so easy to apply these. And the reason I was thinking about this is because, as Matt mentioned at the beginning, I help teach nursing orientation at my facility. I'm actually doing it tomorrow, so that's why it came to mind. But anytime that I'm showing my like our new hires these devices, just so that they're familiar with it, I show them the little metal nitinol feet, and everyone just kind of cringes, like, "Oh my God, like that's in their skin." It's not in the skin; it's in the sub-Q tissue. You don't have innervation in the sub-Q tissue, so as long as it is nice and flat, we're not rocking it back and forth. The patient doesn't even feel it, if anything at all. Also, with our line insertions, we're always giving a local anesthetic. We use lidocaine sub-Q injection. I am pretty heavy-handed with my lidocaine whenever I insert, so my patients are usually very numbed up at that site. They do not feel this going in at all, but again, we already kind of talked. You fold it in half, you've got your little feets. They just go right into your insertion site. And then whenever it goes flat, that's what's holding it underneath the surface of this, or in the sub-Q tissue underneath the skin. And it's like I said, again, as long as you're not rocking it back and forth, there's no pain, there's no discomfort. That's usually the only big thing that I have to tell people, as far as whenever we're educating on dressing changes, is making sure that device is nice and flat, it's nice and parallel. We're not turning it, and we're not turning it back and forth, and we're not twisting it.
I was just about to ask you if I had a patient call you, or I have a patient I'm taking care of, and I've never seen this before, I'm new. All of a sudden my patient's telling me that they're feeling like a pinching sensation at their arm. What would you do? What would you do if you were called in to assist with that nurse and that situation?
So I've actually gotten this call a couple times before, and the culprit has usually been just malpositioning of the line with the dressing application. So again, it was a new staff member. They changed the dressing, and then within a couple hours, the patient was like, "My arm hurts so bad. Please, can somebody do something about it?" And it's because that when the line was inserted, it was laying like this. When we did the dressing change, it is now turned this way and it's kind of tilted a little bit. So all I had to do was just do a simple dressing change, made sure it was nice and flat, let it hang out, especially while we're waiting for our dry time. Again, I'm heavy-handed. I saturate my lines because I do not want an infection. So we have quite a bit of time to just make awkward conversation at the bedside, waiting for our site to dry. And just during the dry time, the patient was already pain-free. And again, making sure that it's nice and flat. It is parallel to the insertion site. There's not any tension on it. And then just putting that dressing on nice and easy. We're not stretching it. We're not doing a pressure dressing. But 9 times out of 10, it is simply just dressing application and positioning of our device.
It looks like Scott has a question.
Yeah, hey, I just wanted to say, I'm glad you explained I've never seen one of these yet, but I was thinking you were puncturing the skin to get it to hold in there, so I had no interest with it. I'm glad you stated what was going on here at the end, so it's nice. Now at least if I see one of these, I know what's going on. Thanks. Appreciate it.
Yeah, of course.
That's probably a great segue. I know you did a mini demo of doing an insertion. I think that's a great segue to kind of taking us through step by step your placement process.
Yeah, of course. So let me just pop this out real quick.
And as you're doing that, I'm going to explain too that the nitinol feet are actually laser cut and polished so that there are no sharp edges. It is completely blunt, flexible spring. So as you're demoing there, it can't pierce the skin in any way, and it can't damage any other structures or the catheter. There you go. I bought you time to get it out.
I'm going to reposition this a little bit.
There
So
you go.
whenever you're inserting the SecurAcath, the one thing that you have to be really mindful of or cognizant of when you're wanting to utilize this device is that you need at least 3 centimeters of external catheter length to accommodate for the length here. So whenever we're doing our measurements, we always take our measurements and add on at least 3. Depending on our patient population, we may add a little bit extra just in case we're very mobile and the line might potentially get pulled a little bit. We have a little bit of a extra safety net as far as line length. But I've done my entire insertion. I'm getting ready. We finalized placement of the line. This is exactly where I want to keep it. What I always do is you can insert it with the stylet or the stiffening wire still in the line, or you can remove it. I typically keep the stylet in my line just to make it a little bit more rigid and help with that insertion site. But I always kind of hold here, and keeping this skin still here, I will kind of pull and provide a little counter traction, and it also helps to dilate that insertion site just a little bit. My general practice is whenever I insert, I do nick just a little bit, but you don't need to nick to apply these SecurAcaths. There's been a couple times I've forgotten to nick and we just kind of put the line in. But again, if you hold here, pull a little traction here, that will help to dilate that site. You can also use your introducer and just kind of poke in there to dilate that site a little bit more. But just like when I was demonstrating with the removal, it folds in half. So I always hold middle finger and thumb, index finger goes right here. And then all I do is just kind of hook in. Hold on, see if I can do this a little bit better for you. So hook in, and then I just insert a little bit, let it go flat. And then my line comes in. It's going to sit right here in that little blue channel. And then you're going to take your little lid, line it up. And then I always snap in the middle here. And then I always want to assess and make sure that each side is nice and snug. There should not be a gap here, and that means that it's fully closed and locked in. And then you're good to go. After you get your securement device on, you can do your final clean, let it dry, and apply your dressing.
And I always recommend that there's a little bit of a tug there that does two kind of inspection things. One is to ensure that you've pulled the legs completely back and you have that centimeter between the catheter and the insertion site, or the SecurAcath and the insertion site. And it also checks that the lid is fully engaged. So even if you hear the click, sometimes there's a partial engagement. And so by tugging, you'll know if the catheter slides at all, that you need to reset it and get that done before you leave the sterile field. So I love that little bit of tug at the end to give you that confidence that you're sending that patient off with a very, very secure line for that first dressing change.
And my little testimonial as to how well this thing stays secured is a lot of the times that we get called for dislodgement of a line, it's usually a consult or request that says, hey, line was pulled, not sure if it's still okay to use. But our SecurAcaths more often than not are still hanging out in our patient's arms, but it's the line is what has gotten dislodged because, like I said, I always call her Ethel, but we have our confused patients that will just pull really hard, or it gets caught on a wheelchair, gets caught on a door. But again, it might just dislodge maybe a centimeter or two, but this thing is still hanging in there. I think the only time I've seen an actual full line removal with the SecurAcath was a patient that was very irate and was dead set on leaving that very second. But again, the line pulled a little bit, and then the SecurAcath ended up coming out, which also reminds me, like Laura had said, the legs here, the little feet are nitinol. They're very flexible. I don't know if you can kind of see that there, but they're very flexible. So even if you were to pull, those little feet just bend and just comes right out. So if the patient were to remove the device themselves, it's not going to tear up their skin. It's not going to cause like massive trauma. It's just going to probably pinch really bad, but all it does is just kind of bend and then boop, comes right back out.
It's designed to fail safely, but to avert that failure, happening prematurely or without intention.
Yes.
Now, Scott, did you have any other questions? I wanted to make sure if you did, you had a chance to ask them.
No, I'm good. Thanks a lot. Appreciate it.
Awesome. I see we have a lot of folks on today. Please feel free to ask questions. I'm looking to see if there were any more posted in our chat. This is a session for you. We want to answer your burning questions and curiosities. Or if you've got a story to share, something that happened and you would like our insight as to maybe what to have done differently, or what share with us a success story. We love those too. So please feel free to post your comments, questions, or unmute and share your story with us.
So Damien, I have a question for you. You were talking about how, for like confused patients or your Ethel patients, right? When they remove the line, oftentimes the SecurAcath is still in place. Do you see any association with like the condition of the dressing, maybe elements of the dressing that were used that might minimize that, or in those situations where it was removed, where maybe an aspect of the dressing was not done completely?
Typically with the line dislodgements that I've seen, it was just someone tugging on it, just tugging on the line, period. So like the dressing was partially removed, like they had just peeled it up and then just like yank. But like I said, the only full line removal I had seen, the SecurAcath came with the line. I think the line had pulled maybe 1 or 2 cms, because I just was curious and I looked into it. I think the line was placed at like 3 or 4 centimeters external, and whenever I showed up at the bedside, it was sitting around like, I want to say 6 or 7 centimeters, the SecurAcath was, and the line, like the whole device had come out. So it clearly, like the line had pulled a little bit, and then just the whole device and everything came with it. All the other dislodgements I've seen were just partials, and like I said, just maybe like 1 or 2 centimeters. One of them was that I did notice that the lid was not fully closed on it. which was interesting because we hadn't done a dressing change on it just yet. And I was the one that placed it. So I don't know who did an unscheduled dressing change and didn't chart it, but it was not fully closed on one of those.
Good. Thanks for sharing that. Looks like Scott has a question. Scott, go
Yeah, it's
ahead.
me again. Sorry, I thought I was done. Hey,
It's all good.
they're big enough to do a temp HD. They're that big. You can get them that big, the lumen on that.
For a 12
Yeah,
or
big-
12.5 French. So the largest catheter we can secure is a 12.5 French.
Okay. Okay, cool. Thanks.
Yeah, the largest lines that I've seen them on at my facility, just because it's my my pick team and then IR that is utilizing these, has been usually like a 7 French for a tunneled catheter. But in our pediatric populations, we do utilize a 2.6 French, and we do use the 3 French SecurAcath on those. But on top of that, we are also, like I said, we're utilizing longer external catheter length, so we can loop it under the dressing, keep it all under there. That way, if the line does pull, because these are little kiddos running around, we have that coiled up length to help minimize tugging of that line on that insertion site. But they are a godsend.
Doing a dressing change on little ones is always a nightmare. I can't even imagine
Yes,
doing that every
is
day.
if you ever want to see me sweat, watch me do a dressing change on a 1.9 or a 2.6 without a SecurAcath.
Without a SecurAcath, right? Are
Any
there any
questions,
other-
anybody?
Yeah, I was just asking
On
this.
stories, anything like that? Scott, I know you probably got one more in you.
Give me
And then
some
I'll talk
time.
about
Give me
that.
some time.
Hey,
So,
Scott, what facility are you at, if you don't mind us asking?
I'm at Sonoran Crossing. It's Honor Health in Phoenix.
Okay.
You guys in Arizona?
Are you north of Phoenix? Like
Yeah, I'm
up
our north, more almost by Anthem.
by Anthem, yeah.
Our newest little hospital. We're only a 78 bedder right now, but my guys, we do all the line work here and respiratory.
Okay, so you carry both duties, respiratory therapy
Yep.
duties and
Yep.
central line placements?
Yep.
Yeah.
HDs,
Okay.
central lines, picks, all of that.
And how big is your team?
I only got on my staff, I only have like 12 people, but I only use 2 per shift, and when I'm here, I got 3 on.
Okay. Okay.
We'll be big someday, but hopefully I'll be retired by then.
Awesome.
Yeah, well, appreciate you sharing and being brave enough to ask some questions.
Yeah, thanks a lot, guys.
Yeah, of course.
I was going to
One
share
thing I'm noticing- Sorry, go
an
ahead.
Ethel story. So we had it was Ethan instead of Ethel. And it was a remote community care center. And the patient was going in and out of mental health status, or, was awake and alert and aware and consented to their catheter placement. And then, just all of a sudden decide to pull their line out. And they did this 3 different occasions. It was a mobile access colleague that was placing these lines. And so on the third time called out to visit this patient within a 3-week period, he's like, I'm putting a SecurAcath in. I need a SecurAcath to put in this patient. And of course you did, but 3 days later, and this is the only time I've ever seen it, but you just shared a story similar. The patient had taken down the dressing, grabbed the entire SecurAcath and catheter and pulled it out and prolapsed those feet. And what was impressive is that you could see the 3 puncture points. It was on the same arm, same track, like, just a couple centimeters apart, but you couldn't tell the difference between the 2 that were secured with StatLock and the one that was secured with SecurAcath. And I think that was really telling for me, and it was early in my time with the company, to understand that that prolapsing doesn't cause any damage. It probably, I'm sure the patient felt it, but they were going to pull that line out one way or another. And there's always that guy out there or that lady out there. I think everybody's probably heard or seen them, But it was important to see that and know the context of all of our published evidence, which says that our failure rates are less than 2%. So to know that, you know, when you think of all the catheters that have been studied, thousands and thousands of them in 29 peer-reviewed publications, that, you know, there aren't a whole lot of ethels and ethans that are successful at pulling these out because it is such a low percentage rate. And it includes, there's actually a study that looked at that patient population, and they too had a very low rate of dislodgement. So if you've got confused and delirious patients, and they're going to ethan or ethyl it, there are other options too to look at creative tunneling solutions, work with your IR docs, and, you know, move those exit sites out of their reach. And that in conjunction with SecurAcath can assure you to keep that access in place. So just wanted to make that throw that out there, because you did share your prolapse story there. And you know, again, it is reassuring to know that these don't cause harm to the patient even under the worst circumstances.
Oh yeah, they are just a huge game changer as far as dressing changes and line maintenance. Every time I go to do a dressing change and it's anything but a SecurAcath, I just cringe. One thing I did want to kind of touch on is how well that it kind of keeps everything sealed in here. Because like I said, if you are applying it correctly, you don't have any kind of gap here. It may look like there's a gap, but it's just that blue channel there, which is like that rubber on either side. So even if you have a patient that is just very anticoagulated, they can bleed, and you can try everything in the book to try and get hemostasis of that line. But almost every time, if you ever have to remove the lid off the SecurAcath, there's usually minimal, if any, kind of blood or drainage inside of the device, just because it keeps it almost airtight in there, because it will keep it nice and snug. But if I ever do have like dried blood on here, our central line dressing kits come with a sterile saline wipe and also alcohol swabs. And so I can just use the alcohol or the sterile saline to kind of get that dried blood off of there before I clean with my CHG swabs, and it just takes it right off.
Mhm. Good. Well, you know, we're encouraging people to ask questions. Hopefully, some of you will think of a question you've always wanted to ask. This is the perfect situation. There certainly are no dumb questions. But I will share that when I'm in the field, two of the most common questions that I hear, and would love to hear your response, Damien, is can a patient with an MRI or that's going for an MRI, can they take their SecurAcath in with them? How do you
Yes.
respond to that situation?
Yeah, so the SecurAcath is MRI compatible up to 3 Tesla, I believe is the number off the top of my head. So they are MRI compatible, they're MRI safe, don't have to worry about removing a securement device just to get a scan done. It can withstand the test of time.
Yeah. When I answer that question, I say almost the exact same thing verbatim. But you know, I also emphasize that really, you know, there's no change to the patient care. You know, any steps really in patient care, unless we're actually talking about, you know, doing a dressing change that applies. So there's no concern about having to change practice or having to really make exceptions here or there. So I think that's a great benefit, because when do nurses usually think about that? As they're rolling into the MRI, right? So it's nice to have that out there, and make sure that that's nothing to be concerned about. So appreciate your response there. The other question that I get possibly even more, and this is usually kind of first impressions, is, you know, can you place SecurAcath, you know, in those skinny or those really cachectic patients? What has been your experience? Maybe if you've had the questions or dealing with that patient population.
Yeah, so definitely it can work with your thin or cachectic patients. It can also work for shallow line insertions as well, because it's going into the sub-Q tissue. And as Laura pointed out, The nitinol feet, they're not sharp, they're very well rounded and they're very flexible. You're not going to puncture the vessel if it's shallow, and you're not going to tear through the skin if your patient is cachectic. I will say, as far as comfort post insertion, making sure that if your patient is very bony, making sure it's like parallel to the bone, so that way your little nitinol feet aren't sticking and poking at the skin there. And then same thing for like frail skin or friable skin. Just making sure that it stays nice and flat. And then, as I kind of mentioned before, you can either do like the gel pad underneath, or maybe some Mepilex or something to provide a little bit of a cushion. Make sure you don't cause any kind of skin injury. Making sure the dressing is put on nice and gentle. You're not placing tension or pressure over it. And then what was it? Oh, as far as shallow insertions, I think the shallowest I've done was, I think my vessel was about 0.3 to 0.5 centimeters deep. I basically straight stuck the patient. But again, the feet are very, very small. Of course, this is like a blown up version of it, but the feet are very, very small. It's only 1 centimeter wide here. And again, just folding it, hook in there, insert just a little bit just to make sure that you're in that sub-Q tissue, and let it go flat. What I've noticed is that you can always make sure that your SecurAcath is very well in place if the feet or the legs, I should say, are nice and straight there. If they tend to kind of cross over like that, that means we're not quite seated too well. But if it goes flat, there's no resistance, and those feet are nice and parallel to each other, you just lay it flat, put your line down the middle, secure it, and then call it a day. But I've not noticed, or I've not seen any problems with shallow insertions or with our thinner cachectic patients.
Yeah, I was just going to summarize it. It sounds like even in those patients where, and, it's good to be asking those questions or have those concerns, but it sounds like there is enough subcutaneous tissue even on those patients to anchor SecurAcath into.
Oh yeah.
Yeah.
And like I said, we utilize this on a wide array of age groups, from just a couple days old, if a day old, all the way up to our geriatric populations on the adult side. So we have a varying amount of sub-Q tissue to work with, and it has worked well with all of them. The only complications that we've seen have been related to dressing maintenance. So as far as like making sure those feet aren't poking the skin or eroding at the skin. Just make sure it's nice and flat. It's not causing any tension, not causing any discomfort, and you should be golden until that line needs to come out.
Mm-hmm.
Anybody else got any questions, stories, anything like that? I'm all ears.
This is usually the point in the session where we start begging a little bit for some engagement, but we certainly like to leave things open for those people that can't make it at the beginning. So we'll see if anybody else that's currently on, and I've seen our numbers fluctuate, so we know that there's new people joining and probably people dropping off here and there. Here we go. Here's an esteemed colleague that can
What's up,
ask a
Sasha?
question.
Damien, you're doing great.
Mhm.
I just wanted to add a little of my experience, because I also like to insert SecurAcath with the stylet in the catheter, because it does make it easy to just slip that puppy right in. But I have had a couple of instances where I do that and I lay the catheter back down, and in lifting up the catheter, I create just a small kink in that stylet that's in the catheter. And so it makes it difficult to really line it up in the channel. So, you do it and then it's not quite in the channel and you can't close it and you're kind of struggling with it. So whenever I do insert with a stylet, I make sure that I withdraw that stylet out from where the catheter is going to be laying in the SecurAcath, so I can snap it on real easy and I know it's secure. And that kink is not kind of messing with the pathway in the channel. So that's my experience. I also really love this device, and I wish everybody would use it for all lines.
Thanks, Sasha. I will say too, you mentioned kinking. One thing, and Damien's shown it this way every time, but I like to highlight with new users, is aligning those wings of the catheter and the printing on the numbering of the catheter, regardless of brand, in that channel, so that that's parallel to the wings of the SecurAcath. When that alignment happens, especially on multi-lumen catheters, you're avoiding any twisting or kinking of the lumen on the interior surface. So it might look smooth, but if those wings are off center, so like the wings of the catheter are like this, while the SecurAcath is like this, and then the dressing comes on and you flatten it, you could be creating a invisible kink, mechanical kink interior on that multi-lumen catheter. So if you can't flush and aspirate at the very end of your placement, that's an indicator that we need to open that lid, get everything all in straight line, and then close that again. And you can reposition it from the insertion site, but it's important to still keep the catheter's numbering and wings in the same plane so that we don't see those interior mechanical kinks.
And then that is actually something that we do assess post device insertion, is that we do flush and aspirate and flush to make sure that we still have good blood return and good flushing after we've placed our SecurAcath. I believe actually, Sasha, you're the one that taught me that.
Fantastic. And Sasha, how long have you been using it? I know Damien's been with the team 3 years, but you've...
Let's see, since like 2017, however many years that is. Is that 7 years? Yeah.
Awesome. And you're still using it now that you're on the West Coast, right? Love it. I followed you there.
One thing to note, it's not like a dead stop contraindication. Some patients that have a nickel allergy I've noticed that they've said they've had a little bit of irritation from it. It's few and far between. I haven't actually seen it to a point where we have to like remove the device at all. The only patient I've seen that has had any like visible signs or like visible irritation with it also had an adhesive allergy, and the adhesive allergy vastly outweighed the irritation to the metal. And so I explained it to them, these are the only 2 solutions that we have. And they're like, just give me the SecurAcath, please, for the love of God. Give me the SecurAcath, because the adhesive allergy was just so terrible. And I believe they still have their line today, and it's been, I want to say, several months, and it's just like nothing.
Sasha, please.
Damien, you might be talking about the same patient, but I've seen it in my previous institution, but also here for patients who do have really severe adhesive allergies. SecurAcath has been the only thing that has kept their line in place. We would, do a Q48-hour dressing change with gauze over the SecurAcath to protect the site. And, those patients who get, multiple lines over multiple years, it's been a godsend, really. It's been the only thing that's allowed them to get the treatment that they need.
100%.
I've heard in patients that are getting like Thiotepa treatments because of the sensitivity to chlorhexidine, especially, and the weeping of the chemotherapy through the tissues, that the only thing that maintains a line, an access line, and is SecurAcath in those patients.
Yeah, we currently have a patient that as one of the services that my team provides is what we call PLABSI coaching. We go and help the nurses at the bedside with dressings that they maintain versus stuff that we take ownership of. And we have a patient that has a PICC line that is very, very fluid volume overload. And like I said, is weeping from almost every pore. And we're having to do, at minimum, Q24-hour dressing changes, if not sooner, just because of how much fluid she's weeping. And this line has not moved one bit. it is her lifeline literally, because like we can't even keep IVs in her, just because they either fall out from weeping or they dislodge because she tends to swell, and then that PIV catheter dislodges from the vein that it was placed in. So she has a triple lumen pick. It has not migrated once from that 4 centimeters external, and we just keep doing biotin and whatever dressings we can get on her. And she's still hanging in there.
It's so awesome to know a little tiny piece of orange and nitinol can have an impact on patient care.
Oh, tremendous.
And, you know, it just goes to show vascular access is such a critical part of healthcare. Like I thank vascular access specialists for all you do, and it is amazing. Yes, midlines. I love SecurAcath for midlines.
I actually, thank you, Sasha. I actually just recently used a SecurAcath on a MST midline, not too long ago, because again, the patient had a history of pulling lines. They were a neuro patient and just altered at baseline, and we didn't have a need for central access, so we decided a midline would be the best course of action because we keep pulling PIVs. And we put an MST in and lasted until the patient needed to get discharged.
Was there any change in your like insertion practices midline to PICC line as far as like measurement and just making sure that there were those 3 centimeters there, or was it actually very similar?
Let's see, whether I'm using the an adhesive securement device or the SecurAcath, there was no change in my assessment or my measurements, just that I need to add on at least 3 centimeters to my measurements, and then making sure that I'm just enough above the AC that I'm not dressing the line into the bend of their arm. But that's just for any kind of line insertion.
Okay.
But yeah, as far as ease of assessment, there's no change in my assessment process, whether I use SecurAcath or StatLock. Just that I need to add on a few extra centimeters.
Yep.
But it also makes the dressing look a lot prettier too, which I'm a fan of.
Yeah. Look good, feel good. Great.
Exactly.
All right, Damien. Well, I don't know that we're going to get any more questions out of our attendees, but everybody that's on and can hear us right now, thank you so much for joining us and participating. We hope that you we hope that you learned something first, and that you understand a little bit more about the product, some of the support materials that are there, maybe even some nuanced facts that you didn't anticipate learning when you registered for this educational event. We do anticipate to have more of these live events in the new year. The schedule has to be set, but we just ask that you stay tuned to the EloQuest and SecurAcath Interrad socials and emails for updates on those items. Maybe we'll even get to have Damien back next year. I think that would be a huge treat for us, and maybe he can share some more anecdotes or stories that as he continues to grow in his own expert profession here, that he can update us on when we return in 2025. So just a quick reminder, all of these educational sessions, once we get a chance to get them edited and posted, are available on the SecurAcath website. So those are very easy to find and navigate to. If you do have any questions, we encourage you, especially if you're in an acute care hospital in the United States, we encourage you to reach out to your EloQuest healthcare rep for any questions that you may have. You can, of course, always visit the SecurAcath website. There is a modulated bot that pops up after you're on the website for a few seconds that you can submit questions to. There is the app. If you haven't used that and you do use SecurAcath in your day-to-day practice, would encourage you to download that and also share that with your teammates that may still be learning about SecurAcath. There's plenty of training and educational resources that we do our best to make available. You can get a hold of us pretty easily if you have trouble finding anything. So we encourage you to reach out and do that. But I think we're going to wrap things up here. There is a plug in the chat. So if you want to click on that link just to get a taste for the clinician resources and educational resources, you guys can do that. But with that being said, I think we're going to wrap things up here. Want to wish everybody a very happy and safe holiday season. And we look forward to supporting you and answering any questions you may have through the remainder of this year and into 2025. So again, thank you for participating in this training session today, and have a great rest of your day.